Hello, and welcome back to our educational video series. While there are many different types of airways stents, and several ways in deploying stents into the airways, this video will illustrate the deployment of the self-expanding laser-cut nitinol stent, from Merit Medical, using fluoroscopy. We present a 57-year-old male, diagnosed with large B-cell lymphoma, who presents with extrinsic compression of the entire left mainstem bronchus. Patient is symptomatic and is yet to see oncology for evaluation and treatment. After evaluation, we agreed that the patient would benefit for airways stenting, to relieve symptoms, and to prevent complete left lung atelectasis. Rigid instrumentation was not an option, due to limited range of motion of his neck. As shown in this picture, the Aero stent is fully covered with a polyurethane coating, and has anti-migration struts that run throughout. It comes preloaded into a dedicated flexible delivery system, and it is deployed through an ergonomic and easy-to-use trigger. It also comprises a proximal suture knot, that allows repositioning, or removal immediately post-placement if needed. The flexible bronchoscope helps delineate the proximal and distal extent of the stenosis, which can be respectively marked with external radiopaque markers. This will help determine the length of the stent that is needed. With this patient, we will be using a 12 by 40 mm stent. The diameter and size were chosen based on CT chest imaging and bronchoscopic evaluation. We used paper clips, that we placed on patient's chest, and secured with tapes. These will help us deploy the stent in the desired location. The guide wire is introduced through the working channel of the bronchoscope, through the stenosis, to guide subsequent stent placement. The bronchoscope is then removed, making sure to keep the guide wire in place. The stent delivery system is inserted over the wire under fluoroscopy control, and the radio-opaque stent is positioned between the two markers. Once the stent is in the desired position, hold the hand grip in the palm of your hand. Using index and middle finger, gently grasp the trigger and slowly retract the outer sheet by pulling back on the trigger, while visualizing the stent deployment under fluoroscopy. When the stent is partially deployed, pause before reaching the no-return point, and verify that the distal part of stent has not changed position, and reposition if needed, then complete deployment. Once the stent is fully deployed, gently retract the catheter and the guide wire out of the airways. Careful endoscopic evaluation of stent position and distension is necessary before completion of the procedure. If the stent's position is too deep, identify the proximal circumferential suture, and grab it with a rat tooth forceps and adjust the stent to the desired position with gentle and brief pulls, making sure not to dislodge it. It is not advised to try advancing the stent into the airways once it is fully deployed. Attempting doing so will cause damage to the stent. The stent can be removed, and placement of a new stent can be reattempted immediately. This concludes our video. We hope these videos will help you gain more practical knowledge in the field of interventional pulmonology. Learn more by visiting our YouTube channel, and please, don't hesitate to leave comments or suggestions. Thank you for your attention. Goodbye.